پێشەوەی دکتۆر سوێ محاضرەکەی دەست بکات تایە هەموویان سەماعەکانتان میوت بکەن هەتاوەکو یعنی ئینتەرەپشن نەبیت و سەوتەکەشی باش بیتن ئەگەر ئەزیەت نەبێت.
بالضبط دەست خۆش دکتۆر.
سپێدا هەمی باش سپێدا هەمی هەواڵمەند باش هەولێرە پایتەخت سلێمانیا پایتەختê ڕەوشەنبێریە و گەل هەمی هەواڵمەند دۆکێ مەدی فەر لێکچارێکی دروستکەین سەر imaging finding covid19 ظن covid19 مشكلتي جواه استا. I think every radiologist has to know every aspect of at least the radiological imaging in chest regarding chest X-ray and CT of the chest. So this is, I think, this is essential because even from now and for the future, it should be like that. Every radiologist should know because it has become a pandemic disease, and we have to diagnose. And many times, the radiologist is the person who is a problem solver. So this should be kept in mind, please, for every colleague. I will go through some introduction. COVID-19 is a viral disease, as we know. It is a SARS-CoV-2. So we had SARS-CoV-1, which is a severe acute respiratory syndrome, coronavirus 1. And now it become coronavirus 2 or COVID-19 because it is coronavirus disease in 2019. And the diagnosis all over the world, they depend on the positive PCR test. It is very specific test, but the problem here, the sensitivity, and the sensitivity is not that good, especially in the early disease. So any person, to be more clear, any person with PCR test positive, he's positive for COVID-19. But any person with negative PCR test, it doesn't mean that he's completely or it is absolutely is disease free. So this should be kept in mind. And the CT fortunately has a higher sensitivity sometimes, especially for early disease than PCR test even. But the problem here is lower specificity. So you may detect you are going to detect every disease, but this disease is not necessary to be specific for COVID-19. So this concept should be kept in mind. And most of the clinical feature, most of them they got fever, but not all of them. This is also important. So not every patient with carrying the disease has a fever. So sometimes it's asymptomatic. Fever, cough, progressive shortness of breath are important. So, but the patient may come for abdominal pain. Sometimes it happens that the patient, especially in the Europe, they reported abdominal pain as a presentation and abdominal symptom as a general. And the patient could be a carrier of the disease with symptom-free, and he can pass the disease to the other person without having any symptom. And overall, the mortality of the disease is around 2%. But sometimes this is overestimation of the disease because not all the patients, they go to the hospital or they may not register. They may keep quarantine at home. So this is also, we have to know this one. Severity of the disease is different. So there may be mild, as I say, no symptom or mild cough or fever. There may be severe from dyspnea, and in such cases, about 50 or more than 50% of the parenchyma, it will be involved radiologically. And about 5%, they may become critical and end with respiratory failure and shock and multi-organ failure. So as you say, PCR test is very specific. This is a good thing, but the sensitivity is around 65, especially in the early disease, and to 95%. And the problem here, it takes time for the PCR test. So it's about 24 hours or sometimes more if there are too many cases. CT scan is readily available, and you can give the report even less than 2 hours with scanning and reporting. And it's very sensitive. And most of the patients, they don't need for contrast, no need for giving contrast. You may scan them for low resolution, high resolution, low dose CT scan or ordinary CT scan. And sometimes if there is doubt about the presentation, so if patient young with severe dyspnea and progressive dyspnea, some changes in the X-ray, you may need to give contrast to exclude pulmonary embolism as a differential diagnosis, or sometimes it becomes a complication of the disease. So this should be kept in mind. But the most important thing in the radiology department is every radiographer, which are in direct contact with the patients and the workers in the department, they have to have a PPE, personal protective equipment, and not necessarily for the doctor, because he may not be available at that time, and he may work on the workstation in other part of the department. But they have to wear masks, gloves, and the apron. And after every patient, they have to disinfect the unit, because this is important. It happens in China especially. Many patients, they got the disease from the scanning the CT. We have initial finding, the commonest one, ground glass opacification, GGO. So ground glass opacification is an initial and is very common, and usually they are bilateral. And I will use the spot. So they are bilateral, and they are preferably located subpleural, and multi-lobules will be involved, and the posterior distribution most of the case. And some of them, 1/3 of the patients, they may develop consolidation as an early manifestation of the disease. Sorry. Okay. And in advanced cases, in advanced phase, this CT scan will develop other findings. So the ground glass appearance will progress, and it will, and reticular pattern will be added, as there is intralobar and interlobular thickening. With ground glass appearance, it becomes crazy paving. So this is combination. And sometimes you will see vascular thickening and fibrotic streaks bands and air bronchogram in case if the patient develop consolidation. And even they end with bronchial distortion and architectural distortion. And subpleural lines, you will see fibrotic band, and sometimes, which is uncommon for the late disease, they may develop pleural effusion. But still, it is atypical finding. I don't know, there's some problem on my side. Okay. The typical findings, I will enumerate some of the typical findings. This is important to write it down in the report. So the report, there will be a template. So you have to know which one is a typical finding and which one is atypical finding. And which radiological finding is a very atypical, so it is most likely it's not going with the disease. The multifocal ground glass appearance, the typical finding, peripheral and basal distribution, and unsharp demarcation, vascular thickening at the area of ground glass appearance. They are round, and they may develop crazy paving appearance, and sometimes consolidation within the ground glass appearance, giving a reverse halo sign and spider web. The atypical finding is when the disease becomes central and peribronchovascular. So they are coming from central. I will show some cases like this, and going to the distribution periphery, but they not reach the subpleural area. And if the disease more in the apical distribution is atypical finding, and lymph adenopathy is also another atypical finding in the disease. Very atypical, which is not going with the disease, is cavitation and calcification, 3 but which a feature of bronchiolitis from onychosis. And nodular pattern is a very atypical, and if it becomes just mass-like lesion or mass lesion and pleural thickening, all these features, they should be reported and as very atypical. نظم دنجم بديت يساوي مشكلة
باشا واضح
اي طبعا ground glass opacification. This is showing a ground glass opacification. So these are foggy appearance, whitish color foggy appearance, and as you see they are bilateral and they are multiple bilateral and peripheral subpleural distribution. So you see the center is paired here, relatively paired, and even the anterior, the posterior one is more common than anterior. So in this case, you see that there are crazy paving appearance. This area of focal ground glass appearance, crazy paving appearance in some area, and in the lower and posterior, you see there are some architectural distortion, as well as there are some traction bronchiectasis and even area of consolidation. Crazy paving, this is a typical radiological finding in crazy paving appearance. So these are ground glass appearance with interlobar and intralobar thickening, so become crazy paving appearance. In the area of ground glass, sometimes there are, especially when you give contrast for excluding pulmonary embolism or as a differential diagnosis, as I said, or as a complication of the disease. So there will be at the area of ground glass, there are vascular dilatation. Normally, you will not see such dilatation. And here there are traction bronchiectasis. Normally you will not see in this region that large diameter of the bronchioli. And at the later stage, you may see subpleural bands and architectural distortion. There are fibrotic bands here. So this a case of young male with a fever about 10 days. So 10 days is important to be reported in the report. A cough and progressive shortness of breath. You will see here ground glass appearance. It is a typical and peripheral distribution, and at the end you will see some area of crazy paving appearance. So this is a typical feature of the disease. So changes, there will be CT changes over time. In early stage, this is important. In the first few days, in the fourth, from 0 to 4 days, there will be the prominent feature is ground glass appearance and sometimes partial crazy paving appearance. And they are lower in number and number of lobes. They are some of them they will be involved, although they are bilateral. Progressive stage will be after 5 to 8 days. There will be some extension of ground glass appearance and increase the crazy paving pattern. So may dominate over the ground glass appearance. The peak stage, the peak of the radiological stage is about 10 to 13 days. There will be, in addition to ground glass and crazy paving, some of the area will develop consolidation, which is uncommon in the early disease. And in the absorption stage, radiological, it's after 2 weeks. So it starts to gradually decrease over time. So this is another case, old age with 2 weeks. This is important. with cough and progressive shortness of breath. And he's a non-case, so he have positive COVID-19 PCR test. So here you see ground glass appearance is dominating. And in the lower lobes, you see there are traction bronchiectasis here and consolidation with air bronchogram and architectural distortion, which is a late manifestation of the disease. Sometimes you face problem with the CT because the patient is very dyspneic or maybe is very elderly. They cannot stop breathing. Stopping of breath or holding the breath is very important to get a higher resolution or CT scan. So here the patient is dementia and he was very uncooperative patient. And he start, as you see, there are some area, especially the lower slides, the photos, they show that they are artifact, motion artifact. So some of the Netherlands radiologists, they make some of the, just like virus and tie rods and lung rods. So they make a universal for reporting. So this is, I see this is more difficult than the ACR by itself. RSNA show that they may be typical. They have to report typical, intermediate, or atypical, or it's negative. So here there are 5. The one is normal, so no feature of infection or maybe normal. And COVID radiology and data system, so it is low because abnormalities are consistent with the infection other than COVID-19. For example, you will see that they are centrally located or not subpleural, and maybe the dominant feature in the early disease is or consolidation. And sometimes really it is difficult to judge on the CT to say is without clinical signs and symptoms of the disease. They are intermediate of suspicion, so you have to report it like this. And if they are typical abnormalities suspicious for COVID-1, for example, some consolidation typical and subpleural, and other, for example, hollow sign, reverse hollow sign, you will see this is high suspicion. If the patient has a fever and only ground glass appearance in the early disease, and they are typical located, so we say it's very high suspicion. And if the patient is already done PCR positive, so it is CoRAS 6. But I see that the RSNA, from the ACR and Society of Thoracic Imaging, they together they make this the consensus reporting on about the disease. So they are typical, either they are typical appearance, for example, peripheral, as I say, bilateral ground glass appearance with consolidation, crazy paving was typical, so say typical appearance. Sometimes it is intermediate, so absence of the typical signs and absence of the atypical appearance like calcification and mass lesion or lymph adenopathy or bronchiolitis like lesions, so it's 3 in bath. So they are atypical, so you have to report that they are atypicals or low suspicion. So either they are high suspicion, intermediate suspicion, and low suspicion, or then the disease is negative for pneumonia from the beginning. So, for example, if the patient has pulmonary edema, it will give you crazy paving appearance, vascular distribution, and you will see other features, for example, pleural effusion, bilaterally, and you see heart problem. So either they are big size heart and with some stent or severe atherosclerotic changes. So as a radiologist, we have to report these in the CT report. This is important, and it is very easy to report it and make it very conclusive report of the CT. So duration, you have to know the history, duration of the cough, for example, or the fever, or the progressive shortness of breath. You have to report it. CT finding, you have to report it. All the CT finding that we have mentioned, the typical and the atypical one. For example, the pleural effusion is atypical. Enlarged lymph nodes, they are uncommon, although they may be subarachnoid infection, and he may have some enlarged lymph nodes. So either you report according to the ACR or according to the CORAT's conduct. I see that the ACR is more practical in the practice to give typical or high suspicion, low suspicion, intermediate, or negative. So, and the severity of the disease, you have to mention either it is mild, severe, moderate. So this is important. If all the lung involved, and some, I will show you some cases, fibrotic bands. So this is severe, and there are features of RDS, respiratory distress syndrome, acute respiratory distress syndrome. If all features, so they are severe. And other comorbidity, for example, the patient have other comorbidity, for example, pulmonary embolism or dissection of the aorta or mass lesion or any other comorbidity you have to mention in the report. And as a conclusion, you say is either this is is typical and it is moderate for severity, it's mild, or it's like this. So and this is a case which is it's after one week of quarantine, fever and cough. So this show you some ground glass appearance, which is typical in the right side upper, and also there are ground glass appearance with some consolidation here. So you see in the right side consolidation of air bronchogram, and even some fibrotic bands in the lower lobes, especially in the right side. This is another. If you report this one, you have to report it at high suspicion because they are typical ground glass appearance. Preferably, most of them they are preferably subpleural distribution. Most of them they are posterior, and the lower are more involved than the upper. So these are crazy paving in the left side, for example. So they are high suspicion. We have not to forget the chest X-ray, because chest X-ray usually they use it as a follow-up for the disease rather than the initial diagnosis. So for the follow-up of the disease, this is important to know the severity of the disease. So these are some pictures of the chest X-rays that have been reported by 3 radiologists that they agree on this severity. For example, here is 64-year mild because there are only some ground glass appearance which are preferably more in the left side, and this is important to mention. The other one, sorry, yeah. Okay. I don't know, I have some technical problem. I will solve it right now. Don't know what's happened actually. Okay. So sorry for that. This is an old age with chest X-ray, which is a mild disease because you only see some ground glass appearance. Another case, which is young one, has chest X-ray for follow-up of the disease. So this is mild severity. You have to know some idea about mild and moderate severity of the disease. So it's another case with some ground glass. I don't know, is it clear for you, for the audience? واضحة يستا chest X-ray okay?
واضحة. بس أقدر عندك explain please كل واحد different level. We have different levels.
The important thing here, you have ground glass. So this one is a moderate to severe disease. You see there is established features of RDS. There are foggy appearance with consolidation, and most of the lower lobes with some sparing of the upper zones. So this is a moderate to severe disease. Here, the patient is middle age, and area, as I showed. I showed you some cases just to be familiar with the chest X-ray, in case of coronavirus hospital for the severity of the disease. To if they want to write the report of the report on the chest X-ray. So here there are established RDS. They are, as you see, they are established consolidation with airborne program with features of ground glass appearance and some sparing of the upper zones. And most of them, you see, they are mostly if you see, they are not silhouetting with the cardiac border. It means that they are posteriorly located, most of them. So this is a feature that are posterior distribution, and they are peripherally patchy appearance in the middle zone in the right side and left side. So this is just like if you see crazy paving appearance in the CT. If the patient is more critical, you'll see more advanced. The disease will be more advanced, and you'll see more opacification, and more even the apical will be involved in most of the zones. And here's another chest X-ray with moderate to severe X-ray abnormalities. This is a young male with a feature with a known case of COVID-19 and area of ground glass patchy appearance and consolidation. This is also another case. Just they did it in the ICU or in the peripheral located, most of them, and most of the lung is involved. And after that, I will show you the cases of severe disease. So this is a chest X-ray of severe pattern of the disease. So is established respiratory distress, and you see, all over the lung there is whitening or opacification of the lung. So this is a typical features of severe type of COVID-19. Is already a known case of COVID-19. And it's also, you see in this case, it's advanced one in late stage. You see most of the lungs involved. You see opacifications, ground glass, or even consolidation, and even you see fibrotic bands, which are very thickening of the interlobular and interlobar bands. And also, this is another one who is young, and all the lung have been opacified. So this is ICU patients, and another old age with all the chest X-ray involved. Most of them, they are upper and lower, and some of the area of consolidation in the upper. But if you see very important sign in chest X-ray, they preserve a little bit in the center. Even in the advance of the disease, advanced disease, you see there is some sparing of the periphery. Just is a reverse Bartwing sign, or it is a reverse of pulmonary edema. So in pulmonary edema, you see the dark color, you see it's white, and in the white color, you'll see darker. So this is just to keep in mind that this is a feature of the COVID-19. And after doing CT scan, you see this is a typical case of COVID-19. So you see they are peripherally located, they are subpleural, and they are more severe. In the upper lobes, they are preserved. So, and the patient has about 10 days to 12 days disease. So you see, there are subpleural located ground glass appearance on some area of consolidation. Even bilateral, most of the lobes are involved. No lobes is immune about the disease. And here, if you see, there are consolidation, there are traction bronchiectasis. I will show you even in. I will show in the coronal view to be more clear. So if you see the posteriorly distributed disease, and you see more clearly in the coronal view that there are traction bronchiectasis, and some of the vessels, they are dilated more than normal. So all these are finding are sequelae of that disease. So ground glass appearance, opacification, consolidation, and fibrotic band, traction bronchiectasis, all have been seen in this. See, most of them, they are posterior. So this is a posterior part of the CT scan of the chest. They are most of, you see traction bronchiectasis inside. There are fibrotic bands. The vessels are dilated. So, and most of the disease is in the lower lobes, or the apical have been preserved. This is exactly about less than 2 weeks, or about 2 weeks. So this is a late stage of the disease. We have to keep in mind all the findings have been seen on this chest CT. Is that the patient has shortness of breath and some talk. So this may be my last case. So here we have we have to think as a clinician with radiology. So not only you pick up, okay, this is our ground glass appearance and this is COVID-19. So it is not like that. You have to think just like a clinician. So out here, you see the ground glass appearance. They are centrally located. So the preserved on the periphery, if you see. So it is not like the cases that I have shown to you. So most of them, they are centrally located and peribronchovascular. So here they are peribronchovascular.
Vale.
Okay. So I will tell you why we have not to report this as a typical features of COVID-19, which is, for me, it's low probability. Because of many things. First, these are peripherally, they are not peripherally located, they are centrally lobular, they are centrally bronchovascular. So if you see here, there is crazy paving appearance and ground glass appearance, but they are central. So they preserve all the way of the subpleural region. So this is one of the features that is against. And also you have not to forget that the patient has bilateral pleural effusion, which is not going with the typical features of coronavirus 19. So there are bilateral pleural effusion. So you have to keep in mind. And another thing, if you make it soft tissue window, you see there are many stents in the heart. So there are many coronary stents. So you have to know that he has some sort of cardiac problem. So one stent, two stents, and even stent in the LID, and even in the RCA, right coronary artery. So there are at least 4 stents in this heart. And another one, which is also against, there are some consolidation in the lower lobe, actually. There are some, but this is maybe you develop any sort of pneumonia. So here there are some consolidation with this marked pleural effusion. It's maybe due to other pneumonia. It's not due to the because they are associated with multiple lymph node enlargement also. So you have to search for the negative or the atypical feature as well as the feature. See, this is a large lymph node. We have not to miss this large lymph node. You see, this is lymph node, a pretracheal lymph node is a there are multiple prevascular lymph nodes. So these are lymph nodes, these are lymph nodes. So as a conclusion, this should be reported as a pulmonary edema rather than with superadded infection rather than COVID-19. COVID-19 pneumonia tends to manifest on the CT scan as bilateral. This is important, and subpleural ground glass appearance, especially for the air disease. CT scan is very sensitive diagnostic tool, but you have to know that it is not a specific one. You have to, although the definite diagnosis cannot be made on the basis of imaging features alone, a combination of clinical and radiographic findings can substantially improve the accuracy of the diagnosis of COVID-19. So always combines the clinical features with the radiological feature. And differential diagnosis needs to be made based on the epidemiological information. And I forget one point is a CT scan of the chest. Really, it is sometimes it is a problem solving. If the high suspicion and you see PCR negative maybe 1 time, 2 times, and if you see that the CT is very typical, so they will deal with them as a COVID-19 case. Thank you very much.
Thank you very much for the question.
I clap for you.
Thank you very much for this nice, informative, brief, beneficial lecture. Really, we appreciate that.